Well, as glaucoma specialists, we always feel bad when we end up having to do cyclodestructive procedures because everything else has either failed or has not been possible. They certainly have improved over the years from when we used to do cryotherapy and other sorts of cyclodestructive procedures, but they're still not our favorite. So when the intraocular pressure cannot be controlled with medications and trabeculoplasty, usually surgical intervention is required. And generally, surgery is aimed at creating better aqueous outflow through Schlemm canal in one of the MIGS procedures, or by bypassing Schlemm canal in the more traditional procedures of trabeculectomy and tube shunts. Ciliary body destructive procedures are designed not to increase outflow but to decrease aqueous inflow by damaging the ciliary body, and the concept of damaging something is not appealing. This is an eye on the right that obviously hasn't done well because it's in the path lab, but you can see the spots here from cryotherapy. So cyclocryotherapy really damaged huge swaths of the ciliary body. These procedures are usually reserved for situations when it's not possible or appropriate to perform an outflow procedure. Eyes with poor visual potential, eyes with such severe scarring that outflow surgeries are not possible, patients who are too ill to go to the operating room, and we generally have avoided them in eyes with good central vision. Some surgeons perform endoscopic photocoagulation in conjunction with cataract surgery to enhance the drop in intraocular pressure that occurs naturally with phacoemulsification and add a few more millimeters of mercury. This is not something that I have done, but some people do perform endoscopic cyclophotocoagulation as an adjunct to cataract surgery. Typically, it's administered either externally through the diode laser or endoscopically, again, typically as an adjunct to cataract surgery. Cyclocryotherapy, which was the mainstay, has thankfully disappeared. The laser procedures are so much safer and so much more comfortable for the patient. Typically do a retrobulbar block, and the diode laser is delivered through a G probe. It has this little button that indents right over the ciliary body. This is the anterior edge. This is the edge that goes against the limbus to line the probe up with the ciliary body processes. It's an 810 nanometer diode light. This just shows the probe in position. In ophthalmic eyes, it's useful to transilluminate the globe to identify the ciliary body location because ophthalmic eyes, everything is distorted and the eye is so big. Traditionally, one would use 2 seconds duration and start with 1500 to 2000 milliwatts, more power being used for the lighter colored irises, and then adjust it until a pop was heard and then back down slightly on the power. 6 applications per quadrant over 180 to 270 degrees, although I have certainly done 360 degrees in desperation. Doug Gasterlin came up with a more gentle laser technique where we use lower power for longer durations. So 1250 milliwatts for 4 seconds in darker eyes, 1500 milliwatts for 3.5 seconds for lighter eyes. There are no pops desired in this. Again, 6 applications per quadrant, same area covered. I have gradually transitioned to this, and I like these settings better. Postoperatively, we give subconjunctival dexamethasone. I usually treat with prednisolone 4 times a day for a week and follow in a month. Thankfully, these patients don't have a lot of discomfort, unlike cryotherapy where we didn't see them for a month because they were in so much pain. Some people use atropine postoperatively routinely and strong analgesics. I have not found this to be necessary. Again, endoscopic photocoagulation can be done at the time of cataract surgery. It only is able to reach a limited amount of the ciliary body. One cannot do 360 degrees with this, and it is an invasive procedure, so to do it as a standalone procedure does require entering the eye, whereas the diode does not. One can do transpupillary rarely, so if the ciliary body is visible in a patient with traumatic aniridia or with a very large surgical iridectomy, then one can directly treat the ciliary body with an argon laser, but this is really very uncommon. Complications, the one we think about most is hypotony. I think this is really rare on the first treatment, but if one requires multiple treatments with cyclophotocoagulation, then the specter of hypotony and ptysis really comes into play. Cystoid macular edema, pain, and inflammation. So the cystoid macular edema, again, I think was a bigger problem in the era of cyclocryotherapy, but we do tend not to use cyclodestructive procedures in people with great central vision. I think the hypotony and ptysis issue is greatest in people who have no outflow. For example, somebody who has 360 degrees of peripheral anterior synechia from neovascular glaucoma, there's really nowhere for the fluid to go, so it takes a tremendous amount of ciliary body treatment in order to get the pressure low. Much more so than if somebody has some outflow. For example, they have a tube shunt that is allowing not enough but some fluid to leave the eye. I think those patients we have less trouble getting control than we do in someone with no outflow. So the key points, we typically reserve these for eyes in which the visual potential is poor or other surgical options are not available. There are concerns about the loss of central acuity, hypotony, and ptysis, and while these are real, they are less common than with cyclocryotherapy. So these are procedures you'll need in your practice because there are patients with glaucoma for whom nothing really seems to work. Surgeries have failed, and cyclodestructive procedures are really the only option left, or people who have such poor visual potential that we really don't, it's not really fair to them to take them to the operating room.